Well, good morning, everybody. It's wonderful to be back in Korea with my friend SJ and the fantastic TCT Asia Pacific course. And to kick us off this morning, we're going to talk about the management of ischemic heart disease in 2025, how the ischemia trial has been an inescapable major turning point in the way we think about coronary disease and refer patients for possible revascularization. So we're going to cover all of these issues. It's a pleasure for me to co-moderate this session with S.J. Park, and we have a great panelists, and we're going to have a fantastic discussion. So let's start out first with a lecture by Sripal Bangalore from New York University in New York City, and he's going to speak about left main and multivessel disease revascularization to set the stage, updated guidelines, and beyond.
Thank you very much, and thanks for having me here, and congratulations on the landmark 30th anniversary. I'm going to focus my talk on left main and multivessel revascularization more as it relates to comparison of revascularization versus medical therapy with some insights from the ischemia trial. These are some of my disclosures as it relates to this particular talk. So when we talk about stable coronary disease, the overarching goal for revascularization, as we think about it in clinical practice, is to potentially improve survival. We want our patients to live longer. We want to prevent other cardiovascular events. So in other words, if we keep them away from the hospital, that's a big goal. And also, very importantly, to improve their quality of life so they live longer and live better. So let's see, in terms of patients with the stable coronary disease, can we achieve all of these with the revascularization therapy? First, let's start with can we improve survival with revascularization? We'll focus on all patients with stable coronary disease and then focus on high-risk subgroup, which is the topic of this talk, left main disease and patients with triple vessel disease. If you look at the overall stable coronary disease trials, I mean, there have been a number of randomized trials, COURAGE, BARRY-2D, and FAME-2. Even though there have been some differences in the results of each of these trials, the one thing which we see from all of these trials is if you look at survival as an endpoint, there has been no difference in survival, whether it's a COURAGE trial in 2007 to FAME-2 trial in 2012. And in fact, if you look at ischemia trial again, the two curves are superimposed and no significant difference in all-cause mortality, whether it's the ischemia trial or the ischemia CKD trial. These are results of the extended follow-up of ischemia trial. This is for all-cause mortality at 7 years. Again, no significant difference between invasive and conservative strategy for all-cause mortality. But if you look at cause-specific mortality, we did see a difference in ischemia at 7 years. So invasive strategy was associated with a 22% reduction in cardiovascular death when compared to conservative strategy. And this difference is to the order of around 0.3% reduction in cardiovascular death with invasive when compared to conservative strategy. And the reason we did not see a difference in overall death in ischemia is a decrease in cardiovascular death was counterbalanced by an increase in non-CV death so that there was no significant difference in all-cause mortality. So if we go back to our drawing board, can we improve survival in the overall cohort? There is similar survival compared with medical therapy alone, but there is a small reduction in cardiac death with an invasive strategy when compared to medical therapy alone. Now, let's move into a high-risk group of patients. What about patients with left main disease? The data for left main disease with revascularization dates back to the 1980s. This is a meta-analysis of CABG versus no CABG trials done in the 80s. And what you see here is an extension of survival with bypass surgery. And as you can see, the subgroup which had the highest extension of survival patients with left main disease. And these were 150 patients enrolled in all of these randomized trials. And since then, every randomized trial excluded patients with left main disease when you're comparing revascularization with medical therapy. And that was also true for ischemia trial. We excluded patients with significant left main disease. So there is data to support that revascularization improves survival, and specifically with CABG, but this is based off of older trials of 150 patients. What about patients with triple vessel disease? Again, if you look at older trials back in the pre-OMT era, the triple vessel disease group of patients also had an extension of survival by 6 months when you follow these patients up to 10 years. What about in the modern era? So this is the latest results from ischemia trial looking at patients with triple vessel disease. We compared revascularization versus conservative strategy, and we also compared the effect of PCI versus CON and CABG versus CON. As can be seen here, revascularization had a high probability of reducing CV death or MI, and this was true for PCI, and also this was true for CABG. But if you look at all-cause mortality as an endpoint, there was no significant difference between revascularization and conservative strategy, whether you compare PCI or whether you compare CABG with conservative strategy. Both the revascularization techniques were significantly effective at relieving angina and improving angina-related quality of life. What about preventing other cardiovascular events? Can we prevent cardiovascular events with revascularization when compared to medical therapy? This is data from ischemia trial where we showed that invasive strategy significantly lowers spontaneous MI. There is a 33% relative reduction in spontaneous MI when compared to conservative strategy, and you can see that the curves continue to separate. This may be one of the main reasons why there is a difference in cardiovascular death in the ischemia trial. We also showed that in the invasive strategy reduces hospitalization for cardiovascular stays. And so with the revascularization, there is reduction in spontaneous MI, unstable angina, and also lowering of cardiovascular stays. And finally, can we improve quality of life with revascularization in stable coronary disease? Again, what we see from ischemia is there is a significant and durable relief of angina-associated quality of life with invasive strategy when compared to conservative strategy. And what we also showed, this is an analysis looking at completeness of revascularization. The functional complete revascularization was in around 58% of patients, anatomic complete revasc in 43% of patients. And when we compare that with conservative strategy, complete revascularization was also associated with significant greater benefit at angina relief when compared to conservative strategy. So we can reduce, improve quality of life. And there is a greater benefit with complete revascularization. But of course, this is not in the patients who are asymptomatic. So if you look at the guidelines, this is 2021 ACC/HA revascularization guidelines looking at stable coronary disease and normal EF. For patients with left main disease, CABG is recommended to improve survival. It's a class 1 recommendation. But if you look at a patient with triple vessel disease, and if the goal is to improve survival, it's now downgraded to a class 2B indication. But of course, if the intention is to reduce other cardiovascular events, for example, spontaneous MI, unplanned urgent revascularization, or even cardiac death, revascularization is reasonable. It's a class 2A indication for those group of patients. If you look at the ESC guidelines, if you have stable coronary disease and EF greater than 35%, for left main disease, it's a class 1 indication for CABG to improve survival. For triple vessel disease, again, revascularization is recommended to improve long-term survival, to reduce long-term cardiovascular mortality and the risk of spontaneous myocardial infarction. So just to summarize the potential reasons to revascularize patients with stable coronary disease to improve survival, there is no improvement in survival overall compared to medical therapy, except in patients with left main disease and LV systolic dysfunction. There is a small reduction in cardiovascular death when compared to medical therapy alone. Revascularization reduces spontaneous MI, unstable angina, and also lowers cardiovascular stays. And finally, and most importantly, there is a faster and more durable relief of angina in symptomatic patients with the greater benefit with complete revascularization. Thank you for your attention.
Great, great. Thank you. We're going to move to the next talk. Dr. Gregg Stone will give us a novel ongoing trials of PCI versus bypass surgery, recharge study. Okay, please.
Thank you, SJ. Well, I'm going to try to tell you that we have to throw out everything we think we know about revascularization therapies, and we're examining this in a new study that's being led by Mario Gaudino, cardiac surgeon, and myself, called RECHARGE. So we obviously know that PCI and CABG are complementary procedures. There have been more than 25 randomized trials performed to date comparing these two. There's no clear winner. Both PCI and CABG are here to stay. So we need to stop thinking like this is a competition. But in retrospect, the designs of all prior revascularization trials have had major methodologic drawbacks that have limited their proper interpretation and clinical utility in guiding physicians and their patients to choose the best procedure for each individual. So Mario and I, along with Mike Farku, who led the Freedom Trial, put a perspective together, published in the European Heart Journal. Obviously, PCI, more rapid, easy, fewer procedural complications compared to CABG. CABG, more durable procedure, fewer late spontaneous MIs and repeat revascularization procedures. Most patients, similar mortality, similar quality of life. But almost all of that data was generated from trials in white men. So this is some of the data from the 5 most recent large randomized trials of PCI versus CABG. And you can see there's been about 22%, 23% women that have been enrolled in these trials, and very few patients who were not white or Caucasian patients. In fact, if you look at Hispanic ethnicity, that hasn't even been reported in most of the trials. We tried to look at this and do a really good job in Excel. 8% non-Caucasian patients, most of whom were black, and 2% Hispanic patients. And what do we know? Black and Hispanic patients are the high-risk groups. Most Asian patients do better than Caucasian patients in these trials. So if we look, both women have worse early and late outcomes after both PCI and CABG than do men, and black and Hispanic patients have worse outcomes after both PCI and CABG than do men. And there are specific biologic, socioeconomic constructs, and other issues that may affect these outcomes. In addition, the way we make all our decisions is to look at the outcomes of MACE, which is death, stroke, MI, and in most trials, repeat revascularization. But this classic MACE endpoint is really leading us down the river because it's got a lot of limitations. First of all, we usually look at time to first event analysis, and that's really flawed. It equates all those events as having the same consequence. But obviously, death is not the same as repeat revascularization. And most trials have a lot more repeat revascularizations than deaths. In fact, even within a single category like MI, procedural MI is not the same as spontaneous NMI. And like if you look at stroke, there's tiny little strokes like the one on the left that barely impact the patient at all. And then there's a massive stroke like the one on the right that causes permanent hemiplegia. These obviously are 2 different entities in terms of their prognostic impact to the patient. The first event takes precedence over all subsequent events. So if you have an early revascularization, that's worse than having a late death in another patient. And it ignores recurrent events analysis. The optimal definition and clinical impact of some of these events has been controversial, and I know this more than anyone from the Excel trial, particularly with procedural MI. And from this trial, this large registry series from Korea, depending on if you define procedural MI by the second universal definition, third universal definition, or the SKY definition, you can get many more procedural MIs with CABG or with PCI or a similar rate, and this can dominate the primary endpoint. Third, revascularization, which drives a lot of these trials, is actually not an event. It's a choice. It's a decision between the patient and the physician, in most cases, to do a repeat angiogram and then consider revascularization. And so it's prone to bias, confounding by indication. There's differential use of stress tests after PCI and CABG. We look for recurrent ischemia. We look for restenosis. We plan on treating it. Whereas after CABG, it's generally told to the patient it's a one-and-done procedure. In addition, CABG failure inherently has less revascularizations. Grafts accelerate proximal coronary disease, causing chronic total occlusions, leading to less targets, and we've learned to avoid PCI and degenerative vein grafts. And most importantly, this MACE endpoint ignores many other clinical events of equal or greater importance to both patients and physicians. What about infections, sepsis, chronic kidney disease, atrial fibrillation, requiring chronic oral anticoagulation for the rest of the patient's life? What about an amputation? That's not anywhere, from vascular complications, not in the MACE endpoint. Major bleedings, transfusions. What about recurrent angina? What about chest pain, even if it's not angina? Musculoskeletal disorders, dyspnea and fatigue, such as from heart failure. What about all rehospitalizations, all other operations, and of course, time to recovery, depression, and cognitive decline? So we've put together this heart team, and the purpose of the heart team, that is the general cardiologist, the interventionalist, and the surgeon, would be to help the patient make the decision to achieve the patient's goals. And I like this cartoon showing how the heart team is propelling the patient over the bar. And so prior to doing Recharge, we conducted 40 semi-structured interviews and focus groups in Spanish and English-speaking patients to identify their priorities, their perceptions of PCI and CABG, and to their barriers of participating in past research. And guess what we found out? Patients don't care about MACE. No one actually even talks about preventing a stroke or a heart attack. They don't think that way. They do want to live longer, but even more importantly, they want to live a full, healthy, happy life. They want to get back to taking care of their patients. They want to get back to work if they were working, to their hobbies, to their vocations and avocations. And quality of life encapsulates all of these non-fatal outcomes that can reflect both the risks and benefits of individual procedures. So with this in mind, we designed the Recharge clinical trials program with full support of the FDA. And this was to evaluate outcomes after PCI and CABG in patient groups with a poor prognosis that have been underrepresented in prior revascularization trials, in whom these differences in comorbidities, biologic and socioeconomic factors compared to white men can affect their absolute and relative outcomes after PCI and CABG. And to develop a novel primary endpoint that encompasses fatal and all non-fatal early and late outcomes after PCI and CABG, not just those 3 or 4 MACE endpoints, to represent both the risks and benefits of each procedure, to overcome the limitations of the classic MACE endpoint, and reflect the outcomes that matter most to patients. So in Recharge, we're randomizing a total of 1,200 patients that are either women, Black or Hispanic patients with left main or multivessel disease independent of syntax score to either PCI or CABG. And the primary endpoint in Recharge is all-cause death or change, that is improvement in quality of life at 5-year follow-up. This is going to be tested in a win ratio hierarchy, all-cause death being more important than the change in generic quality of life, as measured by the SF-12 V2 form. We're going to time average the change in quality of life over 60 months, that is 5-year follow-up. So every month counts exactly the same, reflecting the patient's life journey of how they improve from baseline. We have multiple major secondary endpoints, including assessing all classic MACE endpoints, and in fact, we're adjudicating 20 cardiovascular type events, including chronic kidney failure, atrial fibrillation and arrhythmias, heart failure, and all other adverse outcomes to see how they impact that change in survival and quality of life. So the status of Recharge, it's been funded by the Patient-Centered Outcomes Research Institute in the United States. It's a phased large award for comparative effectiveness research. The protocol has been finalized and central IRB approved. We've selected 95 sites in the United States and Canada, and to date, 55 patients have been randomized. So hopefully in a number of years, we'll be able to give you these new data in, again, these traditionally underrepresented patient groups to see if we can look at a new outcome that is improvement in survival and improvement in quality of life, which reflects what patients want, not necessarily what their physicians have been trying to give them over the years. Thanks very much.
Thank you. So we're going to move next Duk-Woo back from Assam Medical Center, who will give us a DM and the Sripal disease, why we need new randomized study. Define DM trial, please.
Thank you, SJ. So, and my topic is about the new launched trial, is a Define DM trial in diabetic and 3-vessel disease, why we need a new random trial. So, absolutely, for treatment of multivessel disease, it's very 2 different revascularization procedure available. One is the bypass surgery, one is the PCI. Absolutely, you know, this diagram shows the benefit of a bypass surgery, and the most cardiac surgeon like this theory or prevention should be the bypass surgery. And the bypass surgery prevent event driven by flow limiting region as well as the non-flow limiting region, but the PCI just treat the flow limiting region to not prevent a non-flow limiting region. So, and the look back, the multivessel disease, the overall, the last 15 years, many trial was done, and some different primary endpoint composition was used, and the overall, and the most trial, you know, support the bypass surgery was better in the multivessel disease. I think this is a typical example in the routine practice diabetic and multivessel disease and the 67 unstable angina, type 2 diabetics and the RCL region and the proximal mid-arid significant region and the OM branch significant region. This patient is typical case in all the second case in our DEFINE-DM trial and the randomization to the PCI. So absolutely diabetic is global epidemic in the world. And, last 25 years later, in the world, 45% diabetics will increase. In the Asian countries, 73, and even North America, 21% will, increase in the diabetic. This is absolutely global epidemic. So looking at the contemporary guideline, bypass surgery is always a class 1 recommendation in the diabetic and multivessel disease. There is no room for elective PCI for in the diabetic and multivessel disease. And absolutely, bypass surgery is class 1. Poor candidate surgery, PCI can be considered 2A recommendation, although there have been remarkable change in PCI field and no room for elective PCI for diabetic patients. So looking at all the evidence and PCI versus bypass surgery in multivessel disease, and this is a syntax subgroup analysis, and the hard endpoint was no different. Repeat revascularization was much higher. This is the same in the best 10-year follow-up. So, and the landmark trial is freedom and validity. This is a cornerstone of a contemporary guideline recommendation. And the freedom trial at the SMI stroke, bypass surgery was better in the up to 5 years. That was sustained up to nearly 10 years, 7.5 median follow-up. And the validity trial is compared to the OMT and PCI. There is no benefit, and the SMI strong no benefit of the PCI. Bypass surgery survival was no difference at all compared to medication, but the SMI stroke composite outcome, CABG was better in terms of MR reduction. But everybody know well there is still limitation. Contemporary evidence guideline is absolutely based on the validity trial, freedom trial. But these two trials did not use any contemporary drug-eluting stent. It's the first generation drug-eluting Cypher and Texas, no concept of imaging and physiology, no use of SGLT2 inhibitor, GLP-1 receptor agonist. This is absolutely, cardiovascular reduction agent. And in contemporary practice, over the last 10 years, there was a remarkable change. Imaging guided PCI for complex lesion was class 1 recommendation. Physiology adapted is class 1 recommendation in multivessel disease. And also in diabetic patient, this is ADA recommendation. For diabetic cardiovascular disease, we should use as class 1 recommendation, GLP-1 receptor agonist and the SGLT2 inhibitor and as the first line the therapy. So future perspective of diabetic multivessel disease, I think we have much revolution in the PCI field and the second generation and the DB and the background, the advanced medical therapy, SGLT2, GLP-1 agonist, high dose statin, and depth strategy. Would be totally different world. And the DEFINE-DM trial was designing to the contemporary state-of-art PCI versus bypass surgery and the 3 vessel disease in diabetic. 1,400 patients will be randomization. Hypothesis is the state-of-art PCI would be non-inferior to standard bypass surgery in terms of hard endpoint death, MI or stroke at 2 years. Inclusion criteria, we're gonna include the significant 3 vessels disease and the visual estimation more than 50%, exclusion unprotected left main, recent STEMI, cardiogenic shock, severe LV dysfunction, EF less than 30%, more than 2 vessel CTO will be excluded. Primary endpoint is hard endpoint, all-cause deaths, MI, stroke at 2 years, diverse secondary endpoint, including quality of life, will be assessed. Sample size was based on, and the 2-year bypass surgery arm event is 10%. We used the hazard ratio 1.45 non-imperial margin, and the final sample size overall 1,400 patients would be required. So FFR guided, we just treat the FFR physiology significant region, and we're gonna mandatory use of FFR as well as imaging, IVUSO, OCT. Should use the stent optimization. This is a mandatory step in the PCI arm. Bypass surgery and the randomization and the bypass should be done within 30 days, and the complete revascularization was recommended. RIMA to LAD, absolutely mandatory. Off pump on pump decided by the treating surgeon. And in diabetic medication, there was a remarkable change. For all patients, all enrolled patients, we're gonna use SGLT2 inhibitor or GLP-1 receptor agonist. Also, we will do very interactive collaboration with the endocrinologist during hospitalization as well as follow-up status. So, and the current status of the DEFINE-DM trial, until recently, very luckily, 95 centers in the 26 countries in the US, Asian Pacific, many European countries finally to agree participate, and this is just the starting point. Until recently, 31 patients was enrolled. I think this DEFINE-DM trial, next novel and the landmark trial, this is a summary. All the evidence suggests bypass surgery always better than PCI, diabetic multivessel disease. This is unanimously adapted in the contemporary guideline, CABG class 1, PCI class 2B or 3. However, there are several limitations interpreting prior available RCT, and they don't use contemporary advanced PCI technique. We need a new trial comparing imaging physiology guided state of art PCI with advanced GDMT, including new anti-diabetic and cardioactive medication versus contemporary bypass surgery in diabetic multivessel disease. Newly launched DEFINE-DM trial will provide the compelling evidence on novel paradigm change of PCI role as alternative choice of DM revascularization. Is PCI versus bypass surgery debate, and there is some issue remained, multivessel and ischemic cardiomyopathy, stage 3C, ischemic HF trial is actively under investigation. Also, contemporary PCI versus bypass surgery multivessel disease, DEFINE-DM will provide some novel evidence for diabetic patients. Thank you for your attention.
Great. All right, we'll move. Next talk by Nico, the future role of intracoronary physiology beyond Fahim series. Please.
Thank you, SCA. Ladies and gentlemen, in the next minutes, I will try to outline how we should interpret the Fahim studies in the era after ischemia. These are my disclosures. In fact, what did ischemia tell us? That in patients with stable coronary artery disease and proof of moderate to severe ischemia and non-invasive testing, an initial invasive strategy did not reduce the risk of cardiovascular death, MI, or hospitalization for unstable angina compared to an initial non-invasive strategy. How should we place that in the context of the Fahim studies? There were a number of similarities between ischemia and Fahim. They had almost the same inclusion criteria, all patients except LM, same endpoints, death, MI, hospitalization for unstable angina, and the same extension of coronary disease, number of arteries, stenosis severity. There is, of course, one fundamental difference. Ischemia had a randomization before the decision for coronary angiography. It is unique in that sense. The study starts, in fact, at the outpatient clinic, and Fahim 1 and Fahim 2 were studies where randomization took place after the patient was in the cath lab. It is a study in the cath lab. First, let's have a summary of Fahim 1. There were 1,000 patients, 1,005 who were randomized. Half of them were treated upon angiography guidance, half upon FFR guidance. In the FFR guidance group, all patients had, in every stenosis, had FFR measurement, and only if FFR was below 0.80, there was a stenting. In the angio group, every patient with a lesion more than 50% was stented. And it turned out already after 30 days, but that improved over the year, that FFR guidance was much preferable above angio guidance. At 360 days, there was a difference of 5.3%, 30%, that further increased over 2 years, and then it slowly decreased after 5 and 10 years. What you can see here that all the different types of event, DES, MI, DES and MI together, MACE, all of them occurred 30% less in the patients who had systematic FFR, systematic PCI based upon FFR. So the conclusion from Fahim 1 was that once the patient is in the cath lab, there's a difference with ischemia. Once the patient is in the cath lab, a systematic use of FFR during PCI improves outcome by 30% compared to angiography-guided PCI. FFR was measured in 94% of the lesions. Then Fahim 2. Fahim 2 is very interesting. In Fahim 2, 1,220 patients were investigated. They had FFR measurement on all the lesions. When there was not a single lesion which was ischemic, based upon FFR more than 0.80, that is the green group, then the patient was treated conservatively. If there was at least one ischemic lesion, the patients were randomized, either PCI or medical treatment. The results are really astonishing, in my belief. First, let's have a look at the patients who had no ischemia at all. That is the green group. They had a very good outcome, 8% events after 24 months, after 2 years. Let's go now to the exactly similar patients from the angiographic point of view, but who had a positive FFR. That is the red group. And those are the ones who are treating by medicines. They do much worse. But if you take that similar group again, but no randomized to PCI, they do much better, and they even return with their risk to the group of which have no ischemia at all. So what you see is two things. In the first place, that ischemic lesions of similar angiography are doing much worse than non-ischemic lesions. That is red versus green. And secondly, that if you have ischemic lesions and you do PCI, you improve outcome considerably up to patients who are no ischemic at all. That is red compared to blue. The cumulative endpoints in Fahim 2 maintained at 5 years, and then, as you can expect, after 10 years, the groups came more together. So the conclusion from Fahim 2 was that once the patient is in the cath lab, that is again the difference with ischemia, PCI of all ischemic lesions and deferral of all non-ischemic lesions is superior to medical treatment. FFR was measured in 92% of the lesions. What about the FFR use in ischemia? In ischemia, there were also rules for FFR use. It was actually measured in 20.3% of the patients. In ischemia, there was one group, about a quarter, with non-imaging exercise stress testing, that is on the left, and 3/4 with exercise stress testing, that is on the right. In the first group, it was almost mandatory in all patients to measure FFR. In the second group, it should be done in part of them. So altogether, it seems that this number of 20.3% FFR measurement in ischemia indicates quite a bit of underuse of FFR. The other difference between ischemia and Fahim was that in ischemia, only 3 patients per center per year were included. That was unfortunately hampered by Corona, whereas in Fahim and Fahim 2, about 30 patients per center per year were included. So if we have to summarize now the future role of coronary and intracoronary physiology beyond Fahim and beyond ischemia, the conclusions and questions can be, first, how would ischemia have been when FFR had been used systematically during the invasive procedure in almost all lesions? The second conclusion is that there is not any reason to change the conclusions from Fahim and Fahim 2, which, by the way, have been confirmed directly and indirectly many times in many studies. The third point is that once the patient is in a cath lab, irrespective how and why he ended up in the cath lab for CAG or PCI, that then FFR guidance is superior to angio guidance and that FFR-guided PCI is superior to medical treatment. The only exclusion criterion is left main in Fahim 1 and Fahim 2. There is a separate study needed for that. That will be the FATE main study, which will be presented by the next speaker. Thank you for your attention.
Great. Thank you, Nico. So we're going to move. Dr. Jung-Min Ahn will give us unmet need for FFR in the main PCI, FATE main trials. Please.
Thank you, SJ. So I'd like to talk about the main need for FFR in the left main PCI. Here is one case, the diffuse RCA disease and left main shift to there is intermediate stenosis. Is it significant or not? Do we need the stenting or bypass surgery? This is another view. This is a cranial view. So what is your idea? So actually, what is the significant stenosis of left main? Right side is non-significant definitely. Left side is definitely significant. Then there is in between gray zones in the intermediate stenosis. How to decide the significance of left main disease? Traditionally, our definition was diameter stenosis. Pre-combat trial, Excel trial, diameter stenosis more than 50% is preliminary, primary definition of significant left main disease. This data came from the very old studies. Very old studies demonstrate that significant left main disease diameter stenosis more than 50% compared with medical treatment, surgical treatment improved the patient survival. Another study showed that even the more tight diameter stenosis, the surgical benefit is more profound compared with the less tight diameter stenosis. So diameter stenosis is very important. According to the diameter stenosis, patient prognosis is different. Less degree of diameter stenosis, better outcomes. More severe diameter stenosis of even left main, the worse clinical outcomes. Recently, ischemia trial also demonstrated that compared with the less significant left main disease, less than 25%, intermediate left main disease, 25 to the 50%, intermediate left main disease increased the patient outcomes. In addition, there is some interaction, the benefit of invasive treatment to reduce the spontaneous myocardial infarction. More severe left main intermediate disease, the more benefit to reduce the spontaneous myocardial infarction. However, angiography analysis for left main is very poor reproducible and inaccurate. So instead, sometimes we use the IVUS. Traditionally, the value is 7.5, but recently, European studies show that more than 6.0 square millimeters in significant left main, less than 65 is a significant left main, but we define the minimum lumen area of significant left main to predict the FFR less than 0.80 was 4.5. So we consider the less than 4.5 minimal lumen area very significant, more than 65 insignificant. In between, we need something. So from the 2018, the intravascular imaging was considered the 2AB indication to evaluate the significance of left main disease. The more recent guideline also 2AB indication to evaluate the intermediate stenosis of left main disease. But the intracoronary imaging also has some limitations. There were two angiographic of left main. Left is a very diffuse disease, right is very tight stenosis. But if you measure the FFR, left is 0.71, right is 0.89. Look at the inside by IVUS. This is a diffuse disease, very small lumen, large plaque burden, so we can guess this is significant left main, but angiographically, definition-wise, non-significant left main. Right side was very tight, looks tight, but the lumen is very huge, but the eccentric lumen, so the FFR was negative. Such kind of mismatch was very frequent in the left main disease. Usually non-left main disease mismatch is more frequent, but the left main disease reverse mismatch is very frequent because even though the left main is intermediate or mild stenosis, supplying myocardium is huge, then FFR could be below the 0.80. So in addition, FFR-based deferred, the clinical outcome is favorable. More recent data from the Swedish Heart Registry show that the differ by IVUS, differ by physiology looks fine, but the physiological differ show that the lower mortality rate compared with the imaging-based differ left main disease. But the FFR measurement in left main, there are some technical issues, particularly, for example, the osteal disease. So because of guiding catheter engagement, you should disengage the guiding catheter to measure the FFR very accurately. So in addition, for the left bifurcation disease, may affect the FFR measurement because left bifurcation is not a single disease. More than 90% of bifurcation disease involve the circumflex and LAD side. So practically, we measure the FFR LAD first, and circumflex we did not measure frequently. So if either FFR is positive, we have to treat the left main bifurcation because a single digit unit, we cannot separate treat it. Practically, we measure the LAD FFR rather than circumflex FFR. In addition, lots of left main disease associated with the downstream disease. If there is some downstream disease, FFR sometimes false positive or sometimes false negative. So Bill Ferron nicely demonstrated that unless downstream disease is very significant, its impact is mild. So less than 0.45 LAD FFR, impact is huge, but more than 0.75, the impact is not significant. So in addition, if LAD FFR is more than 0.85, left main FFR, all cases more than 0.80. So in addition, if there is some tandem lesion left main and distal LAD disease, we can apply the tandem lesion concept of FFR. So we measure the FFR and pressure wire pullback 0.77, 0.90, 1. Pressure difference is greater in the LAD disease, so stand first LAD, and then we can re-evaluate the left main disease. FFR is 0.84, we can defer the left main disease. So come back to the first case, we measured the FFR, so FFR was 0.79, so IVUS was 3.9, minimal lumen area at the ostium, and shaft was 3.22, so significant left main disease. We put the stent. So I'd like to introduce the phase 2 main trial. So what is unresolved issue of left main physiologic evaluation? So benefit of FFR evaluation in the left main disease is unresolved issue. So we evaluated. We compared the FFR guidance and angio guidance for treatment decision and evaluation of a significant left main disease. So we randomly assigned to the FFR guided decision arms around the 400 patients, angio guided decision arm around the 500 patients. Primary endpoint was a 2-year composite endpoint. So we already enrolled 19% of patients. So I think the phase 2 main trial gives us a new concept and new idea and scientific evidence of left main physiologic assessment. Actually, this is our first live case. This year is the TCTAP 2025. 1 hour later, we will show how to deal with the left main by imaging and FFR. Thank you for your attention.
Great. Okay, so we're going to move Samir Mehta here. He will give us some master's key case and reviews as multi-vessel PCI in acute coronary syndrome, decision making with FFR or intracoronary imaging. Samir, please.
Thank you, SJ. Hello, everyone. Looks like a great turnout, great meeting this year as usual. So I'm going to shift a little bit from stable disease to unstable coronary disease and maybe think about physiology in a slightly different way. So I'll start by the case, 49-year-old male, acute inferior STEMI, and the culprit lesion was the right coronary artery with 100% thrombotic occlusion of the proximal vessel, underwent primary PCI of that vessel with restoration of TIMI3 flow. Patient had significant non-culprit disease. There's a tight proximal LAD lesion of about 80% and a less tight lesion in the mid-circumflex with some ectasia in the mid-portion of that vessel. Now, this patient was lost to follow-up and did not come back for staged PCI until 4 years later when he developed recurrent chest pain, called 911, and the ECG on the scene showed acute inferior STEMI. So he was brought back to the cath lab, and the stent in the initial culprit, the right coronary artery, was widely patent. There was some disease progression in the distal vessel with perhaps slightly more ectasia, but this was not the culprit accounting for his STEMI. When we shot the left side, you'll see here that the acute culprit lesion was that more moderate lesion in the circumflex artery. And the LAD lesion was essentially unchanged, and you'll see that here. So this is a case where, you know, we actually did do physiology in that LAD lesion. The physiology was actually positive. The FFR was positive in that proximal LAD lesion, but it's an example of where if we had treated the proximal LAD, we would have actually missed the culprit, which was in the more moderate lesion in the circumflex. And we've all had cases like this. And this is the nature of acute coronary syndrome. We cannot change that. This is the pathophysiology of the disease itself. So we know that if we do an angiography-guided approach in all vessels, there is a benefit. A complete trial established that definitively, that there is a reduction in hard clinical outcomes when we try to achieve complete revascularization. And we have data that will be forthcoming at hopefully TCT this year, showing that it's actually the completeness of revascularization that matters. The more complete the revascularization, the better the outcome for hard clinical outcomes. And this is now a Class 1A recommendation on both sides of the Atlantic. So the European guidelines and the AHA-CC guidelines have listed complete revascularization as a Class 1A recommendation. So the same level as primary PCI, very highest level for PCI in the guidelines in these types of patients. However, there are still many unanswered questions. And I think a lot of the questions that we have had have been driven by this analysis. This was a core lab analysis in the context of the complete trial, where we did angiographic core lab analysis on some 6,000 to 7,000 coronary angiograms within the context of the trial. And we looked at lesions that were angiographically tight, so more than QCA significant stenosis, 60%, versus those that were not so tight. These are the non-culprit lesions. And we found that essentially all of the benefit of complete revascularization was in the tighter non-culprit lesions. Whereas if the lesions were less tight, so remember about 60% QCA is very roughly equivalent to about an 80% angiographic lesion, okay? So it's, I mean, given all the limitations there are with angiographic eyeballing of lesions. But this is about 1/3 of patients that had less tight lesions. So if in fact this analysis is true, and we don't know if it's true, it's a subgroup analysis and we have to treat it as such, that this is a hypothesis generating analysis. But if in fact this is true, then we may be able to refine how we do PCI. Now, we can't do QCA in everyone, but we do have physiology, and we saw very nicely in earlier presentations how this is a validated approach in patients with stable disease. But in the unstable situation, it's a very, very different situation because the pathophysiology of the disease may be what's driving future cardiovascular events. And I'm showing that on this slide here. So this is the full spectrum of ACS. On the left-hand side, you have the stable CAD patients where you have thick fibrous caps, you have smaller lipid cores. These plaques are less likely to rupture, and physiology works very well in this situation. In fact, it's a Class 1 recommendation in our guidelines. But if we go to the extreme right side of this slide, we have the situation of an ACS where the pathophysiology determines what happens to these patients. This is plaque rupture, and there is thrombus in this vessel. This is a medical emergency. Nobody would ever put a wire down a STEMI and decide if they're going to do STEMI primary PCI when that patient comes in with ST segment elevation. Now, I'm being a little absurd, but I'm doing it for a reason. The reason is that this is all the same disease, right? This is coronary disease. Here, we use an angiography-guided approach to save a life, okay? What about those non-culprit lesions that we find in that STEMI patient? Do they resemble more the left side, the stable CAD, or the right side, the STEMI plaque? And that's what will determine how we treat those lesions. And in fact, if you look at multiple studies, I'm not going to go through them all because it's not a 1-hour lecture, but if you look at multiple studies, regardless if they're OCT imaging, NIRS IVUS, or CTA, they all show that about 50% of these non-culprit lesions are thin cap fibroatheromas. They reflect, or they're similar, more like the lesions on the right side rather than the lesions on the left side. It's somewhere between 45 and 55%. So let me just show you a case. So this is an inferior STEMI. This is a 60-year-old male, came in with an inferior STEMI, and the culprit in this patient was in the circumflex. Okay, so he underwent on the left-hand side primary PCI to the circumflex, opening the vessel. But he had non-culprit lesion disease in both the LAD and the right coronary artery that you see there. Okay, and this patient was actually randomized into the Complete 2 trial, and he was randomized to a physiology-guided approach. So here's the first non-culprit lesion in the LAD. He had physiology done, and it was negative. RFR was clearly negative, 0.93. Then we did intracoronary imaging on this patient. And intracoronary imaging shows very high-risk plaque in this patient, 360 degrees of lipid arc, lipid infiltration in this plaque. So again, very high-risk plaque. And similarly, in the right coronary artery, the RFR was negative, but again, very high-risk plaque. Here we actually see thin cap fibroatheroma, we see macrophage infiltration, we see cholesterol crystals, and probably the highest risk feature on OCT imaging, even more so than TICFA, is intraplaque hemorrhage. And there was intraplaque hemorrhage in this vessel. So how is this lesion going to do in the long term? We know that there is data that shows that if you have complex lesions like this, you do worse prognostically. And the other important point is that things may change because plaques are dynamic, so that with lipid-lowering therapy, over time, we may see stabilization. Some plaques may become stable, other plaques may become less stable. This is a dynamic process, so it's quite a complex process that we're talking about. But we are looking at this issue in the Complete 2 trial, where this is going to be the largest physiology-guided trial ever performed. It will answer the question of how to treat non-culprit lesion disease in patients with ACS. This is a trial of more than 5,100 patients. We just crossed 2,000 patients in the trial. By this time next year, we should be finished. We're looking at patients with ACS with one additional non-culprit lesion, at least one additional non-culprit lesion, and they're randomized to receive a physiology-guided strategy where we only do PCI on physiologically significant lesions, or an angiography-guided strategy, which is essentially the same strategy that we used in the Complete 1 trial. We have a very large OCT study, again, the largest OCT trial of non-culprit lesions ever performed, 1,500 patients, where we'll be looking at intracoronary imaging in these patients, and we'll be looking at hard clinical outcomes over a long-term follow-up of 3.5 years. And this is the OCT part of the study, which is a very important part of the study. We'll be able to see in particular in the physiologically negative lesions whether or not the pathophysiology of the lesion or the imaging is better able to predict events than just the using physiology alone. And this is now well underway, and hopefully we'll have results for this in a few years. Thank you.
Great talk. So we are going to have a limited time, however, panel discussions. Greg?
Thank you. Greg, your study design is really interesting, right? Because, as patient mentioned to you, is not one single event, and every patient has a slightly different interpretation of what that. Some patients are very tolerant of having multiple PCI, and some people say one more, I'm going to go to surgery. So maybe just clarify for me, how do you sort of add all these together for individual patient events? Is just quality of life, or is it like you count some of these different events after their intervention?
So the primary endpoint is the change in survival and quality of life analyzed by win ratio. Mm-hmm. So we have the hierarchy, and so we look at individual pairs of patients. And first we look to see if those pairs of patients, if one lives longer than the other. Mm-hmm. If yes, that dominates that outcome. If not, we look at the change in quality of life between the two pairs of patients, with at least 5 points being a significant difference. So we're independent of why their quality of life is better or worse. Presumably it has a lot to do, but not totally, on the type of revascularization, the procedure they had, both the benefits from that revascularization and any short-term or lingering long-term effects from complications of the procedures.
Okay, thank you.
Any? Myeong-Ki, Hong, any comment on that one? No?
So one of the studies that I thought was really, 6 really interesting studies presented, so thank you to the presenters. The study of Jung-Min Ahn, FATE main trial, I guess, one of the questions that many of us would have would be, where does imaging fit into this? Because the discrepancy between imaging and FFR, maybe 30% disagreement, and so would your trial be still adequately powered if people are using imaging up front, or are you excluding imaging up front for these cases?
So thank you very much. Very important questions. So in both the group, the imaging guided stent optimization is mandatory. So the intracoronary imaging only used for the post stent optimization. Before the decided the significant or not, we do not use the intracoronary imaging. So only angio and FFR.
I'd like one question to Dr. Mehta is, what is your opinion for the current publication of the PREVENT trial for the treatment of the vulnerable plaque?
I think it's a very intriguing result. And congratulations, by the way, on doing that trial. The one thing about that is that we know that there is a direct correlation between the plaque instability and the degree of stenosis, whether you want to use plaque burden, diameter, stenosis. So the tighter the lesion, the more likely that lesion is to be an unstable plaque. So in the PREVENT trial, you looked at lesions that were much more moderate. So the probability of an unstable plaque in those lesions decreases, which makes imaging all the more important, I think, when we're looking at those type of lesions.
What I mean is that what is the clinical application for from the interpretation of the PREVENT trial? What should we do in the real practice?
I think if you're thinking of doing PCI on an FFR negative lesion, then physiology is absolutely mandatory to show that that is, in fact, an unstable lesion. I don't actually think we're quite there yet. I think we need some replication. We need some additional study on this topic. But ultimately, I mean, let's face it, this is the way PCI is going. We're going to be so much smarter, 5 years, 10 years from now, because we're going to actually treat the pathophysiology of the disease. We're not just going to blindly put stents in lesions because, that's what we've been doing for the last 20 years. It's going to become so much more refined, where we're actually going to look at the plaque and we'll have some idea, and AI will play a very big role in this. AI will tell us which plaques we should be stenting, which plaques we shouldn't be stenting, and we're getting there. But it's going to take years before actually, at the point where we're able to do that.
So Mehta, so actually I think it's the recently in the BioVasc, in the multi-stars, in the overall randomized clinical trial demonstrates STEMI with multivessel disease, complete revascularization is maybe superior or not inferior to the stage PCI. So in the acute setting of the STEMI with multivessel disease, do you think it's the FFR, it's non-culprit region, is really acceptable or is somewhat debatable issue?
It's a bit controversial, isn't it? What we do know about it is that entire trials have been done using FFR in the acute setting. The Compare Acute trial, for example, that was led by the group in the Netherlands, showed that there was a benefit of doing acute FFR. But I share your concerns about that. Our practice is to do a staged procedure and do FFR in a stage setting. But we do have evidence to support that, and the guidelines do point towards doing a single-sitting FFR-guided complete revascularization procedure as a reasonable way to proceed.
Any others? Okay, really.
Just one more question is that, the sort of medical treatment arena is changing so quickly, right? In terms of diabetes, in terms of, we can get people's LDL to 20 or less with injections, as well as probably drug coming out to treat the Lp(a). So that's the hard part about comparing treatment like this, is that things are changing so quickly as time goes on. I would say a lot of the lesions that are sort of borderline critical probably can be treated medically over time. So I think that's the part, maybe any comments from anyone, that how this changing arena of medicine that we can give to patients are going to affect the trials that you want to do?
Yeah, it's a great comment. I can tell you that within the context of Complete One, medical therapy was very high. So we're talking statins, statin therapy. But I think you're right, LPA treatment. Roxanne is leading a huge trial with IL-6 inhibition. I mean, these treatments essentially stabilize plaques. They do what we are trying to do from an interventional perspective. But it's hard to do that. And particularly, the larger that unstable plaque, the harder it is to actually stabilize that plaque. And I showed you a case where, even though the FFR or the physiology was negative, these are highly unstable plaques. Intraplaque hemorrhage, for example, is a very lethal finding. If I had a plaque with an intraplaque hemorrhage in there, I would be very worried about a major event within the next year or so. And then next down from that would be a thin cap fibroatheroma.
Anyway, as I'm looking for the complete 2 studies, right? Still up. Anyway, up at this point, and FFR guided decision making, treat or not treat. However, that we will learn something from prevent trial. Just still, I got just the beginning, and so we have Dr. Ahn. We have some subgroup analysis about the vulnerable plaque definition. There are many variables, just still ongoing. How much strong predictors for the event in sometimes or something like that. So just the OCT guided, the CABG, and that would be one of those. However, still. We have lots of issues, to treat or not treat based on the imaging concern, right?
So let me extend it to Shamir because, look, congratulations on complete 2. We're going to learn a tremendous amount. But it's interesting that it starts in that trial with randomization to FFR guidance versus angio guidance.
Right.
So the FFR guidance is going to basically identify 2 types of FFR positive lesions. One that are TICFAs or other high-risk lesions, which we know are the types of lesions from multiple other vulnerable plaque trials that are really the high-risk lesions. And then we're going to identify the FFR positive non-TICFA lesions, the more pathologic intimal thickening, fibrocalcific plaque, which, Sripal, Bangalore would tell us from ischemia, we shouldn't be treating those patients because they were, quote, silent ischemia. They didn't bring the patient to medical attention. So, when you said that, this was basically the end-all and be-all trial, there really needs to be a third arm, which would be OCT identification or another imaging identification of truly high-risk plaques, because there will be some of those TICFAs that may be FFR negative that may also be at high risk, as suggested in the PREVENT trial, despite the fact that it was relatively lower risk chronic coronary syndrome patients.
Yeah, no, I completely agree with you, Greg and SJ. That was going to be complete 2. Where we do an imaging guided strategy. But we ran into one issue when we were writing the protocol, actually, is that we're not there yet. So our ability to predict events with OCT imaging is close, but it certainly is not there yet. And we do not have all of the variables. The inter-individual variability is huge with OCT imaging. So in order for this to be a tool that we are going to use widely, it's ultimately probably going to come down to AI. We can't look at a binary, measurement of the, fibrous cap thickness. It's going to be a continuous variable, and there are all of these other features, lipid arc and so on that need to be considered. So this is way beyond you and I as just eyeballing, an OCT image and saying, oh yeah, that's a high-risk plaque, that's a high-risk plaque. It's going to be the AI that tells us, no, that is actually a high-risk plaque and it's associated with a recurrent event rate of X, and you should probably do PCI on that. I think that's the direction we're looking at. So that's complete 3, Greg.
Okay.
Yeah.
Okay. All right.
Thank you.
Okay, thank you. We're gonna move on next. Exciting master's debate session. So the combat is usually exciting. So in the OMT First, in the interventionist side, spiral bilateral First, and next the surgery is still standard. David Portaga will give us talk.
Thank you very much. All right, so I've been asked to take the stage on OMT versus surgery for multivessel disease. I'll make a case for OMT first. No relevant disclosures for this, but I also want to point out I'm an interventional cardiologist. I have debated Dr. Taggart before, so for people who have heard this, it may sound boring. So I thought what I'm going to do is, let me spice it up a bit. Okay, so we'll do a bit of a switcheroo, and I'll take his stance. And I'll try to prove to you guys that surgery has to be the standard of care for all multivessel disease. Why should that be the case? I'll show in the next few minutes or so the CABG actually improves survival in patients with stable coronary disease and multivessel coronary disease. And even though I'm an ischemia investigator, I'll show that ischemia results does not apply to patients undergoing CABG. I will also try to prove that medical therapy or PCI does not reduce MI, and because of all of these, surgery has to be the standard of care. So I'll make it easier for Dr. Taggart. I'll try to prove all of this. So let's try to prove that CABG improves survival in stable coronary disease patients. And of course, the things that we hear over and over again is, every surgeon will show the STITCHES trial and say, look, CABG improves survival. STITCHES, CABG versus medical therapy in patients with heart failure, significant mortality benefit of bypass when compared to medical therapy alone, number needed to treat of only 14. On the other end of the spectrum, the recently published Revive BCIS2 compared PCI versus medical therapy in patients with heart failure reduced EF. No significant difference either in death or heart failure hospitalization or all-cause mortality. People have used these two trials to say CABG works, PCI does not work in patients with the reduced EF. But is that really the case? STITCHES was done 2 decades ago, and there have been significant progress in medical therapy for heart failure reduced EF. Here you can see the 4 pillars of medical therapy, and studies have shown that if you use all of these, the relative risk reduction in all-cause mortality is 74%, absolute risk reduction of 25%. So this leads us to the question, if CABG was to be pitted against modern medical therapy, will it come out to be superior? In fact, there is this publication, a trial-level publication of the STITCH and Revive BCIS2 trials comparing outcomes. What I want to point out is the green is the medical therapy in STITCHES trial, the orange is medical therapy in Revived. In between are the curves for CABG and PCI. The real winner between STITCH and Revive 2 is the medical therapy in Revive. So you can see a significant decrease in mortality with medical therapy in Revive when compared to STITCHES. So this begs the question, if CABG was to be pitted against a modern medical therapy, will there really be a survival benefit? So I want to point out the question we are not debating is, does CABG improve survival in patients with multivessel disease and reduced LV systolic function? STITCHES already proves that CABG does reduce mortality in this group of patients, but as I pointed out, this is not against modern medical therapy. We are also not debating whether CABG improves cardiovascular death. Ischemia actually shows that invasive strategy reduces cardiovascular death. The question we are debating is, does CABG improve overall survival in patients with multivessel disease and preserved LV systolic function? Let's see if there is data to support this stance. I mean, this is in the pre-OMT era, so 3 decades ago, 80s and 90s, comparing randomized trials of no CABG versus CABG. And as you can see here, CABG was associated with the reduction in mortality at 5 years. But if you look at 10 years, I know many of our surgical colleagues will say we have to wait long enough to see the benefit of CABG. But it's interesting to note that back in the day when there was hardly any medical therapy, the curves between CABG and no CABG tend to converge. The way I see that is with CABG and survival, there is a first and upfront procedural risk. Then there is a long period of benefit, and then there is a late risk when graft starts to go down. Now, if you look at the trials done in the 80s, now let's add a touch of medical therapy for those and look at modern trials. So if you look at the Courage trial, Barry 2D trial, and Fame 2 trial, the commonality of all of these trials is no significant difference in death in any of these trials. The same was true for ischemia and ischemia CKD, no difference between invasive conservative strategy for all-cause mortality. But if you focus specifically on CABG, this is the Barry 2D CABG stratum, comparing patients with diabetes, multivessel disease, CABG versus medical therapy alone, and no significant difference in survival, even with CABG in patients with diabetes and multivessel disease. MAS2 trial, again, PCI, CABG versus medical therapy, again, at 10 years. I know we'll hear a lot about longer-term follower. CABG versus medical therapy, no significant difference in mortality, even at 10 years in in MASS2. This is the ischemia results on patients with a triple vessel disease. So we looked at revascularization compared to con, and we separately looked at PCI versus con and CABG versus con. Significant difference in cardiovascular death or MI favoring revascularization, whether it's PCI or CABG. But if you look at the endpoint of all-cause death, no significant difference, and this is also applicable when you compare CABG versus con. Both PCI and CABG significantly improved angina-associated, angina-related quality of life. So the first statement that I wanted to prove, CABG improves survival, is a fallacy. Benefit was seen in older trials with no medical therapy, and the curves converged at around 10 years. What about the notion that ischemia results does not apply to CABG? So here is a list of all of the CABG versus revascularization trials. I mean, this is not CABG versus PCI trials. This is CABG versus revascularization randomized trials. And you can see all of these sample sizes. So you have the BARI 2D, MASS2, VA study, European study, CAST trial. You can see the sample sizes here. The number of patients who got bypass surgery in ischemia far exceeds any of the prior trials. And here is a summary of all of these trials. And if you look at mortality reduction with CABG from each of these trials, the predominant answer from each of these trials is there is no difference in mortality with CABG when compared to medical therapy alone. So again, it's a fallacy that ischemia results does not apply to CABG. More patients in ischemia underwent CABG than any trial of revascularization versus medical therapy. How about the last notion that medical therapy or PCI does not reduce MI? We know from a number of randomized trials, I want to go into all of these, that a number of things that we do, diet, weight loss, cardiac rehab, smoking cessation, intense statin therapy significantly reduce cardiovascular events. This is the OMT analysis from ischemia trial comparing patients with no OMT goal attainment to patients who had all of the OMT goals attained. Significant benefit at reducing cardiovascular death or MI if all of the goals were attained. We also showed from ischemia that invasive reduces spontaneous MI, and this was true for both PCI and CABG in the ischemia trial. So the notion that medical therapy or PCI doesn't reduce MI is again a fallacy. Both medical therapy and PCI reduces spontaneous MI. So the question we are not debating is, does CABG improve survival in patients with multivessel disease and LV systolic dysfunction? The ACC/HA guidelines gives CABG a class 1 indication in LV systolic dysfunction, but I truly believe that we need to revisit this. And does CABG improve cardiovascular death? Again, the guidelines cover this. It's a class 2A to revascularize these patients to reduce the risk of cardiovascular death. So the question we are really debating is, does CABG improve survival in patients with multivessel disease and preserved LV dysfunction? And for this, the ACC/HA guidelines gives it a class 2B, saying the CABG may be reasonable, but no definitive evidence. So my final thought is medical therapy with or without PCI is enough for most patients with multivessel disease and preserved LV function, with CABG reserved for those with complex coronary disease. Thank you for your attention.
Move on. David, Tagat, please.
Thank you. Good morning, ladies and gentlemen. I'd first like to start by thanking the organisers, especially Dr. S.J. Park and Dr. Duk-Woo Park, for the invitation to be here at this very important 30th anniversary of TCTAP. This is my 15th visit to this meeting, and I'm delighted to be back. I've been given quite an easy remit this morning, which is to answer why surgery is still the standard for most patients with complex coronary disease, despite the results of the ischemia trial. My conflicts of interest are clinically, I'm a cardiac surgeon, and I do have some commercial interests, but none of them relevant to this presentation. This is quite a complex slide, but if you look at the best available evidence, leaving ischemia aside for a second, looking at CABG versus medical therapy based on 4 trials, MASS1, MASS2, BARI 2D and stitches, we can see that CABG has superior survival therapy, emerging at around 5 years and accelerating past 10 years. And what's important about these trials is at that time the patients did have a reasonable optimal medical therapy in terms of aspirin, beta blockers and statins. If you look at the ischemia trial, it's one of the most widely misinterpreted studies. This was a trial of initial invasive or conservative management of stable coronary artery disease, excluding patients with left main, over 5,000 patients with moderate or severe ischemia. It was not, has been widely interpreted, a trial of PCI versus CABG, although it has been interpreted as that, and I'll show you how it has adversely affected guidelines. And it's very important to realize from the outset, ischemia patients are not typical of routine patients who undergo CABG in clinical practice today. We've seen this slide. If we look at ischemia out to 8 years with a median of 6 years of follow-up, total death, no difference between the invasive and conservative strategies, but for cardiovascular death, reduced in the invasive group. But therefore, that means there was an increase in non-cardiovascular deaths to make the overall deaths similar. Now, again, this is an important slide. Dr. Stone's one of the authors of this, along with my good friend Mario Godino, and it looked at outcomes according to coronary revascularization modality in the ischemia trial, published in JACC in 2024. The first thing to note is if you look at the conservative group, 22% of them had no invasive therapy. PCI was the most common therapy in almost 60%, and only 20% of patients had CABG. And yet this was used to downgrade the recommendation of CABG versus PCI. If you look within the groups, we can see that almost 60% of patients with 3-vessel disease were in the invasive CABG group. In the other groups, it was around 30%. These are not patients we see in routine clinical practice who need revascularization. There was no indication of total deaths in the group. In terms of cardiovascular death, it was about half in the PCI and the CABG group, and also about half for spontaneous myocardial infarction. Revascularization was not quoted. So in the basic data we have here, CABG and PCI seem to be superior to a conservative strategy. Now, to my amazement, Dr. Bangalore has just told us there's no advantage of CABG in patients with 3-vessel disease. So I'm going to recommend he reads a trial called the Syntax trial. This is actually a pretty well-known trial, and it showed conclusively at 5 years in 3-vessel disease, if you had CABG compared to PCI, you had a significant reduction in overall death, cardiac death, myocardial infarction, repeat revascularization, and no risk of stroke. Now, why do I talk about Syntax? It's easily the most important trial ever of PCI versus CABG because it was a relative all-comer trial. Syntax also showed us the importance of the severity of coronary artery disease according to Syntax scores. So if you had intermediate or high scores, your survival advantage at 5 years was 7% for the intermediate group, 9% for the high-risk group, and accompanied by marked reductions in myocardial infarction and repeat revascularization. So when Dr. Bangalore says there is no evidence of the superiority of CABG over PCI, I find that quite astonishing. If you follow these patients out to 10 years, you can see the survival advantage of CABG is almost 40% and continuing to diverge at 10 years. And this paper by the esteemed Dr. Patrick Sorois looked at the Syntax trial, not only the randomized component, but the all-cohort component, and showed that in both of these, CABG has a marked superior survival. He wrote, with a nearly complete 10-year vital status, the trial shows a realistic CABG to PCI treatment ratio of 4.7 to 1, highlighting surgery's long-term survival benefits over PCI. Choosing a revascularization modality should depend on an individual's long-term prognosis rather than an average treatment effect. Additionally, patients should be informed about their predicted prognosis, and I hope Dr. Bangalore will read this paper. If you look at what we tried to do to change the results of Syntax, it was the FAME3 trial, and it addressed 2 limitations of Syntax. It said Syntax did not use FFR, so we'll use FFR. And Syntax used an old generation drug-eluting stent. So in Fahim 3, they used zoterolimus, the best available drug-eluting stent. But if you look at the primary endpoint at 1 year, CABG was superior to PCI. What happened at 3 years? Well, the authors changed how they presented the results. They removed the primary endpoint and changed it to a concept of death from any cause, myocardial infarction or stroke. But if you actually go back and look at the primary endpoint, CABG was highly superior at 3 years. The MACE risk in the PCI group, 18.6, 12.5 for CABG. Now, this paper had 40 authors. It was widely reviewed by statisticians, reviewers, editors. And you have to ask, was the change of the way the results was presented, was everyone asleep? Or was this an intentional attempt to disguise the primary endpoint? For non-diabetic patients, CABG is widely superior, as shown by Dr. Saroy's and Dr. S.J. Park. For patients with diabetes, Dr. Bangalore talked about the Barry 2D trial for diabetes from well over 10 years ago. He didn't mention the most definitive trial of PCI and CABG in diabetes, the Freedom trial. He didn't mention it. Why? Because it showed a very clear survival benefit of CABG over PCI. If you look at patients with ischemic cardiomyopathy, we've seen the Stitches trial mentioned several times, clear survival advantage of CABG. And in this updated study of almost 5,000 patients with ejection fractions below 35% by Mark Gruel's group, and matched for 30 baseline characteristics, CABG again showed a marked improvement in survival, marked reduction in MACE, myocardial infarction, repeat revascularization, and no difference in stroke. But Dr. Bangalore insisted there is no evidence about the superior survival of CABG. We've heard the REVIVE trial. It showed there is clearly no role for PCI in patients with ischemic LV dysfunction. No difference in primary outcomes, secondary, death, MI, hospitalization, or repeat revascularization. So I will finish with this slide. We keep hearing about improvements in PCI, and this is a slide I've been showing for almost 20 years, but there are 3 fundamental differences between PCI and CABG, which show why CABG remains the superior therapy for patients with coronary artery disease. Placing bypass grafts to the mid-coronary vessel means that you make the proximal culprit lesion irrelevant, but you offer protection against future development of new proximal culprit lesions. Tom Lucer showed 3 decades ago in the New England Journal of Medicine, if you put an internal mammary artery on the LAD, it reduces the risk of further disease development in that circulation because of the release of nitric oxide and other vasodilatory protective agents. And for many patients, PCI means incomplete revascularization, and that's been repeatedly shown to correlate with increased mortality and increased MACE. So I would argue these are the 3 reasons that despite the enormous technological advantages in PCI, there is still a survival benefit of CABG over stenting. It really doesn't matter what kind of stent you use if you're aware of these 3 different pathophysiological mechanisms. In my very final slide, I'll show you this. These were the ACC-AHA guidelines in 2021 based on the ischemia trial. And what they recommended was a significant downgrade in the class of recommendation for CABG from 1A to 2B. Now, this was based on ischemia, which wasn't a trial of PCI versus CABG. And it ignored, these guidelines ignored an enormous body of existing data showing the benefits of CABG over PCI. It was all ignored. And these guidelines were correctly rejected by every society of cardiac surgery worldwide. And the real importance of this is these guidelines are a real danger to patients. because interpretation and use of these guidelines will mean that many patients with significant coronary artery disease will no longer be offered the long-term survival benefit of coronary artery bypass grafting. My final statement is to advise everyone to consider this book, State-of-the-Art Surgical Coronary Revascularization. It's a book edited by myself, my good friend and colleague John Puskas. It has 72 chapters on CABG. You think, how can you have 72 chapters on coronary artery bypass grafting? But it covers every pre, intra, and post-operative aspect of the operation. On that point, I'm going to conclude my talk. I would like to thank the organizers, especially Dr. S.J. and Duk-Woo Park, for the invitation to be here at this 30th anniversary celebration, and to the audience for your attention. Thank you.
So I just listening to the two talks, and I think it's really helpful to still kind of think about, for individual patients, the decision sometimes is not so simple. Meaning that, you know, if you look at a 90-year-old that has significant 3-vessel disease, it's very different from a 3-vessel disease in a 60, 70-year-old person, because the activities that we ask them to do and what endpoints we are asking the patient to be looking at, just like Gregg, in terms of the quality of life issues, not necessarily just sort of these hard endpoints. So I think still, my message always to our patients is that, you know, we have to look at these data very individually, meaning does it apply to them, and help them to decide a decision that will impact their life and the quality of their lives the best. So that's kind of how I approach these patient population.
So, you know, I'll make a few comments. You know, this was supposed to be a debate on medical therapy versus surgery.
Right.
Actually, didn't even have PCI in the title, okay? And in that regard, I mean, I would agree that ischemia was not a trial of surgery versus medical therapy. It was a trial of invasive angiography with revascularization compared to medical therapy as a first approach. So I do think that ischemia has been overinterpreted by some as whether it applies just to PCI or just to CABG. And similarly, though, I would say that Sripal was right. Other than ischemia, there are no recent trials of medical therapy versus revascularization, whether PCI or CABG, except for possibly Revive BESIS 2, and before that, Stitches, in the poor LV dysfunction trial. And Sripal nicely made the point about differences in medical therapy. There's also differences in patient size between those two trials. Stitches was twice as large. It took twice as long to show a mortality benefit. They had higher risk patients, et cetera, et cetera. But the biggest comment I would make is, why are we only talking about mortality? Okay, we're arguing about 2 to 3% differences in mortality. Okay, maybe 1% difference per year. Is that significant? Is it real? Even if you looked at Dr. Taggart's curves, in most of the trials, the curves are just a little bit different. So if you've got a 5% difference in mortality, which many of us would think is large, that means for 19 out of 20 patients, it makes no difference whatsoever. Okay? And patients have told us that there are things that are even more important to them than survival, which is why we're doing recharge. And we don't revascularize patients just for survival. We revascularize them to relieve angina, to prevent myocardial infarctions, even though we don't have a lot of data that that's the case compared to medical therapy, and for a whole host of other reasons. And hopefully we do it so in a way that we don't cause harm. Okay, where we don't have lasting effects from the complications of the procedures. So I just think we have to get a lot more sophisticated in the questions that we're asking and the trials and the studies that we're designing to answer those questions in a way that are meaningful to patients.
I think one of the problems that we talk about when we talk about optimal medical therapy is, you know, most patients aren't on optimal medical therapy. So, for example, in the ischemia trial, only a third of patients reached, you know, quite lax LDL targets of 1.8. I mean, they're much lower now in guidelines. Even at 1 year, only half of them reach those guidelines. And actually, you could probably get the same level of survival benefit as Dr. Taggart reports in CABG by being more aggressive in lowering LDL. I mean, for example, the Fourier trial with that PCSK9 inhibitor had an absolute risk reduction of around 2.5% in 2 or 3 years in high-risk patients with cardiovascular disease. So I think we have to be very mindful of what we actually mean by medical therapy.
Could I just make a quick comment? The first thing is, I did not understand this was a debate of optimal medical therapy versus CABG. I understood it was a debate about had ischemia changed the practice of the way we should treat patients. And my argument is therefore very clear. I don't think ischemia has. But to me, it was not a direct debate of optimal medical therapy versus CABG. The second thing I would say is that if you look at the totality of the evidence, it's impossible to read the evidence with an open, transparent mind and say there's no evidence of the superiority of CABG over either optimal medical therapy or PCI. The evidence, in my opinion, is overwhelming. The question to me is, why is that advice not often given to patients?
I'd like to remind one is that in reality, what I mean is in the multivessel disease, this is a multivessel disease, you need the surgery and directly transfer the surgical department. And what is the reality? 1/3, 2/3, or half of the patient return back. I have a discussion with the surgery, and I don't want to take a surgery. Maybe we have another option. That is a usual, real situation. You strongly present the request that the surgery is a surgical benefit. But in reality, most of the patient, I don't like to take surgery. We have a very frustrated, okay, surgery and it's done, but the patient come back again. In the reality, number of the patients so much high. What can we do? We have to do the guideline-based practice, but number of such kind of too much high. So that is a real problem in the real situation in the practice. So why this kind of difference is maybe some medical system is different for the UK and our country. You know, in our medical system, patient decide the PCI and then okay, today is the date for the PCI, but suddenly change it. Oh, I'd like to change my mind. I take a surgery. 1 week later, quick change, and take the plan to the surgery. No, I don't want it, and the quick change in the PCI, very quickly. It's up to the patient and their family decision.
All right. Okay, there's some time. All right, I'd like to, summarize. If we have Sripal disease, preserve the LV functions. Actually, the ischemic, cardiomyopathy, less than 35% ejection fraction, CABG is better, right? And so I would like to just as Bangalore's side, Sripal disease, ejection friction preserved, the 1 or 2 major vessel PCI and medical treatment enough. That is the first one. And Sripal disease, preserve the LV functions, so a little bit complex anatomy, and so we have to send the patient to the surgery, right? That is second one. Which one? Otherwise, the first option from the Bangladesh ones.
Is the patient having angina? Is the patient having heart failure?
Angio.
No, angina.
Angina. It's
having chest pain and heart failure.
No, of course,
Or is it an asymptomatic walking well patient? Which is being managed well with medical therapy. Those were the kinds of patients.
If so, the patient had an ischemia, moderate to severe ischemia. But define a little bit different. So however, Sripal angiographically, moderate to severe ischemia, and preserve the LV function. Just the Bangalore side, 1 or 2 major vessel PCI and medical treatment, and send the patient to surgery. And so I would like to, ask some opinion from the panel.
But symptoms or no symptoms?
Symptoms, yes.
All right.
Symptoms,
No,
ischemia, preserved
yeah.
LV function.
Okay, so say the patient's having symptoms of ischemia, like angina and heart failure.
All right.
Okay.
Because EF is normal, right?
No, he said,
Normal.
preserved. Is
Normal.
preserved EF?
Preserve.
No, wait, preserved or reduced?
Preserve the LV
Okay,
function.
preserved triple vessel, preserved EF, Okay, and angio.
So, Greg, what would you do there first? Bangalore side and the other side?
For me, it would depend on the coronary anatomy. If the patient, wants symptom relief, the patient needs revascularization. That's the best way to get symptom relief. The patient has preserved ejection fraction. So it would depend in part how complete revascularization I think that you could achieve with PCI versus CABG. In that patient with contemporary techniques, I don't think there's a major difference between PCI and surgery in terms of survival. There might be in some patients a small benefit of surgery, but I don't think that's the major overriding factor. So I would offer both to the patient if I thought I could get complete or near complete revascularization. If I can't, if there's 2 CTOs that I can't open up, then the patient should go to surgery.
Great. Nico is the last one, right? We're going to move.
Opinion, coming back to the discussion between Gregg and SJ, a quite big pitfall when comparing these studies with PCI versus medical therapy or CABG versus medical therapy. And that depends on the crossover of patients. It is not always mentioned how large this crossover was, but the most pronounced is, for example, in the ORBITA trial, well known to you. In the ORBITA trial, 40% of the patients in the medical assigned group had a crossover in the first year. If you would do a real honest trial, you should in fact forbid this crossover. And if that would have been the case, many of these 40% of the patients would have had an infarction or even died. So in fact, in my opinion, this kind of studies, you cannot call a study comparing medical therapy compared to PCI. You should call it a study comparing PCI today versus PCI in the next year. That would be really honest. So I think that all these kind of studies are very difficult to interpret because you are not sure what would have happened to these patients in the medical groups if that was forbidden to do the crossover. That's the big problem.
But part of the strategy is allowing crossovers. So these are strategy trials, right? So if, for example, in the medical therapy arm, if you don't need to cross over in 3/4 of the patients, that's okay. That's part of the strategy. So how do you do in 100% of the patients, including 25% like in ischemia that needed a revascularization, months or years later? That's the strategy.
Yes, but Greg, the point is that you are also talking about subjective well-feeding of patients. If I'm participating in such a study, and I'm randomized to the medical treatment group. The doctor has convinced me, oh, sir, you will be safe with medical treatment, you do not need a PCI, etc. And then 3 months later, I have severe chest pain at rest, and I need to have an urgent PCI. Does that make me happier? I would have hoped that I would have assigned beforehand to the PCI group. Then I would have been a happier patient.
Okay, thank you for hot discussion. This really, endless debate. We're going to move to the opening session in the main auditorium. Right? Okay. Thank you for joining us. Right? Good discussion. Okay. Very good.